Hello, my name's Sharon Whyte. I'm talking to you from the University of Washington and speaking to Caring for the Caregiver. My specific role is I'm a registered nurse and I work in cardiology, but I also work with a team called the MCS team, Mechanical Circulatory Support. It's a huge umbrella term for ways we support patients' hearts if they are failing. So I work with the MCS team as well as the palliative care team as kind of a coordinator within the Regional Heart Institute for the University of Washington. So today we're talking about caregiving, and for an MCS patient, the mechanical circulatory support patients, we have various devices we implant. Our highest volume are our LVAD patients, which are left ventricular assist devices. These are devices that we implant in the left ventricle of the heart, and they ideally will improve quality of life and extend life for patients, and but they are wrought with potential complications. And the caregiver role becomes a huge part of the journey for these patients. And we speak to our caregivers as if they are the patient. They are 50, as I introduce myself to them, I say to them, you are just as important as our patient getting the LVAD, because their job is huge. When our patients are discharged after the LVAD implant, and their length of stay can be anywhere from 10 days to literally 10 months, that 90-day clock starts ticking where they cannot be alone. And I'll explain why in a minute. We need to demonstrate to our patients and caregivers all the needs of an LVAD patient. And again, hopefully they will go home and feel better and have a much better functional status. But these pumps are wrought with potential for having CVAs/strokes, GI bleeds, both in the head and anywhere else. Lifelong infections, they have a big drive line coming out from the pump within the heart, and it comes out through the skin and onto a battery connector. And if the caregiver doesn't do excellent sterile dressings, the patient could get infected, which could ultimately lead to sepsis and therefore death. So it's a huge responsibility. Subarachnoid hemorrhages and other neurologic events. And sometimes we have frequent readmissions just for little things. Their INRs need to be within a tight window so that they don't clot their pumps or bleed too much. So frequent trips to the clinic. Initially, they come at least once a week. And if you live right down the street, that's no big deal. But if you're from Alaska or Montana or even Yakima, it's a huge caregiver burden. Some of our patients have extended lengths of stays because of all the issues above, and the caregivers, although they have nurses at the bedside, it becomes a huge burden for them because their loved ones don't want them to leave. They have to not maybe potentially be at work, all kinds of other variables that they are managing. And in addition, there's a lot of burden upon the caregiver, especially if they have an extended length of stay, because they are wrought with decisions that they have to make. If somebody has a stroke, the caregiver has to, and the patient literally cannot speak for themselves. Do they want a trach? Because they need long-term ventilation, a PEG, a feeding tube. Would they want dialysis? Would they ever be willing to go to a long-term or short-term nursing facility? So that's a huge burden for caregivers to hold, especially if they're making it in isolation. So there's just sheer exhaustion of supporting a loved one, both physically, emotionally, and logistically, financially. And really the patient is so focused on their own health and recovery, all these other issues become the burden for the caregivers. So this is too busy of a slide to read. You may want to pause it at a later time, but I have two different patients here, WW and JD, and they have complete opposite experiences as far as their caregivers are concerned. Patient WW had an LVAD placed in June of 2016. His wife was Mary, and he was literally only out of the hospital for 5 days in a 9-month period and ultimately did not survive. He had multiple complications, and he wanted her there at the bedside because that's how their relationship worked, and he was, I think, quite fearful. So, and all along the way, she had to make endless very difficult conversations. It was just a really hard time for both of them, obviously. But Mary's response when I made a bereavement call to her was, I was never told how horrific this could be. She was exhausted. On the other end of the spectrum, patient JD had an implant in April of 2011 and ultimately died on January 2017, which is a very good length for a patient with a destination therapy LVAD, meaning they aren't going to get a transplant for reasons I can't get into right now. But his caregiver was his wife as well. It's not always the spouse, by the way. Patty was her name, and she had excellent support, excellent communication, tons of support from her family. She was very savvy healthcare-wise, and patient JD had multiple complications, some frequent readmissions, but she was able to provide care for herself and therefore be a strong caregiver for patient JD. When his end of life planning began and there were some really difficult decisions to be made, Patty expressed gratitude and demonstrated, incredible courage. She attributed this to feeling completely surrounded and supported for JD's more than 5 years with his LVAD. And on her bereavement call, I quoted her as saying, I had no idea what being his caregiver would entail. It was such an honor, never a burden, and I have peace in knowing JD had quality of life in his last 5+ years he was given. So incredible differences in their experiences, and I have literally 100 different caregiver scenarios I could share with you. The complexities are quite huge. So caregiving in the LVAD population, we always meet the patient initially, but we want to suss out who the caregiver is, and what their sense of what they're signing up for is. It's very hard to describe to them what they're signing up for, but we can't. We just do our best. We do advanced care planning. I know everybody knows about that. And we always try to develop rapport building in our consultations, both with the patient, of course, but equally as important as the caregiver. Some resources that you might want to look at are mylvad.com. That's for our patients, but there's a lot for the caregivers as well. And this article over here on the right from NIH is an excellent article about caregiving, the burden, the experience, and I highly recommend it. So if you have any questions, this is my email, and I thank you a lot.